we had approximately 895 was the steroid arm.
Okay.
So what we did was we went retrospectively back enough to look at patients that had the NSAID 2 days pre-op. We do an NSAID for 10 weeks post-op, and then do the steroid taper over 4 weeks or so. And then and so we compared that arm with eliminating that steroid and then and replacing, essentially that steroid with OMIDRIA in the operating room. When we initially went to 10 weeks, we were looking at the data, the published data on CME, how long, what's the peak incidence of CME post-operatively, and it's usually 6 to 8 weeks, and we stop using our products right around then. So I said, well, let's extend what we do to 10 weeks. So that's how we wound up with that base protocol where we were using the steroid for 4 weeks, the NSAID for 10 weeks post-operatively. But that data's old.
Right.
Those studies are
Right.
that they're extra caps, et cetera. So then we ultimately started pulling back, but not after we switched over to OMIDRIA. So we had a good period of time where we just quit the steroid, used the OMIDRIA, and then had the 10-week post-op NSAID. And so we took the patients up until we started to change the NSAID down to 6 weeks and 4 weeks, so that you could compare apples to apples with the 10-week.
Right. And so I've always had that theory that even though you see that incident so much later, it's from the surgical insult earlier on. Mm-hmm. And so I think that's why OMIDRIA makes sense to have that on board during surgery, and then your topical NSAID can cover it, for a few weeks. But I think you figured it out, but you don't need it for like 10 weeks. Right. So I think that's what happened. We see the peak incidence of CME, but it's from 4 weeks before, or maybe 5 weeks before, where the insult occurred. So it just takes a while for the macula to respond, I think.
Yeah. The interesting thing for me with the data when I started looking back at it is I actually really didn't think I was going to find anything. I was like, oh my gosh, this is so many patients. This is so tedious to have to go back and look at all this stuff. And I said, it's just not going to be different at all, because you're right. You had 2 in 500. It's so few patients that wind up with CME. But then when you actually statistically look at how many were in each group, we had 3 times the rate of CME in the steroid group than we did in the OMIDRIA group.
Wow. What was the actual numbers on that?
It was about 5.8% with the steroid, and then it was less than 2% with OMIDRIA.
Right.
And then we also looked at the extra post-op visits for if they came in with photophobia 2 weeks or 4 weeks or whenever up to their 90-day post-op period, or if they had some rebound iritis where we had to add a steroid in or go to a stronger steroid because we had been using Lotamax, we bump up to Durezol or something. Mm-hmm. And it wound up being twice as much in the steroid population of rebound iritis and photophobia, and as in the OMIDRIA group. So it was actually half the amount when we used OMIDRIA. So it just made post-op so much easier.
Right.
That 90-day post-op period. Not only did we have less chance of CME, but we had less patients coming in for extra visits with
reasons.
Problems after their surgery, discomfort, etc.
So that's interesting. We almost got the exact same data just looking at the CME. Our criteria was anybody who had loss of best-corrected vision less than 20/30, we do a scan on them. Okay. And so that's how we picked up these 2 little cases of CME, because they actually, most of the time it's negative.
So they were almost subclinical.
Yeah.
The
so
patients
almost
weren't
subclinical.
even complaining.
Right. But a lot of these patients, are 70% of my patients get the femto, so they're looking for a really good refractive outcome with, good distance vision.
Yes.
And so if your best corrected is 20/30 and you're expecting 20/20, what happened? Get an OCT, and then, most of the time it was negative. But on the cases that it wasn't negative, we saw a little blip of CME in 2 cases out of the 504, so it was really low. Mm-hmm. And then both of them resolved. One within 3 months went back to 20/20, and another one took 6 months, and they got back to 20/25. And that case was interesting because now I do OCT preoperative on everybody, but that case actually didn't get an OCT preoperatively.
Oh, so
I'm not sure, it might have had some sort of intraretinal cyst ahead of time.
Now, did you exclude any patients in, for example, if they were at higher risk for CME, like they had pre-existing vitreomacular traction or diabetic retinopathy or anything like that. Did you exclude those patients?
We did, yeah, we did exclude, most of our exclusions were lack of follow-up from co-management, which is about 200 out of the 800 or so. But then there were some patients that, yeah, either if they had a history of, let's say, retinal vein occlusion or severe diabetic retinopathy, or if they had preoperative OCT that had an epiretinal membrane, we didn't include those in the study.
Yeah, we did the same thing. You know, if someone was just diabetic, we didn't exclude them. But if they had, you know, diabetic retinopathy that had just gotten quiet, or they had a
microaneurysm here and there,
right,
yeah.
epiretinal membrane present or something like that, then we took them out of the count, so to speak.
Yep, exactly.
None of the patients in the study that we looked at had any adverse effect from the OMIDRIA. You know, just like you were saying, if we identify an allergy to either one of the components of the drug, then we don't give it to the patient. So
right.
We had nobody make a mistake.
Yeah, that's a good thing.
and you know, it just was a really positive experience. We didn't look at so much the outcomes after, you know, we found CME or this. We just looked at the incidence of that.